All right, y'all. So put on your best face. Yeah, as Marcy said, I'm Beck Whipple. I am the statewide suicide prevention coordinator for the Department of Behavioral Health, Developmental, and Intellectual Disabilities. It only took me 9-10 months to get that whole title, so we're doing good. But yeah, so we're here today to just talk about kind of Kentucky and where we're at with suicide, and more importantly, we'll go over some stats, but more importantly, we're going to talk about action. And I'm going to invite folks into different types of action because this is something, suicide and the prevention of suicide and the intervention of suicide is something.
Can you help me?
Going to take all of us. And so I hope that I am a very informal trainer, and I want to be as much of a participant as you all are. So if there are questions throughout any of this that if I use an acronym you don't know, or say something that you're unclear of, please just let me know, raise your hand, unmute yourself, however you want to do that. And yeah, we'll go from there. But before we start, I want to say a little bit about me. I am from rural Kansas. I grew up in rural Kansas. I came to Kentucky about 21 years ago. And I am a person with lived experience of suicide. And I think that in any situation I'm in, I bring that experience, that personal experience that I've had, and hope and am passionate about preventing that for folks in the future. And if we can't prevent it, then making sure we have trauma-informed and trauma-sensitive responses to those that are needing kind of clinical care, and destigmatizing clinical care and suicide as a whole. So that's kind of the tenets for me. I'm huge about purpose over personality. So we might not all in the state see eye to eye on different things, but our general purpose, or my general purpose, is to work with whoever, whenever, however I can to prevent suicide. And so, that's something that's really big for me too. And so that kind of just is a little bit about me. And so a lot of times when I speak about this, I'm speaking from firsthand experience about the psychological distress and the psych ache that can be a factor in suicide. And suicide is not something that is a one factor deal. It's not, it's a whole gamut of things that kind of combine together that increase a person's risk. And so if it was just a one kind of cause, then we would have a lot easier avenue in intervening and preventing. But there are lots of different things, and for lots of different people, it is something that does not discriminate based on age, sex, race, class. It does not pick. And so we do know that there are groups that are potentially more at risk, but that's not to just say that lots of folks. So I first encourage folks to think about, when they think about somebody who is or could be suicidal, to think of what that image looks like, to be really honest about calling up, like, what does that come to your mind? Is it a person that looks like me that's in a professional role, or is it that person that has different so I just call you to think about that, and to really examine where those notions come from, and to try to work to undo some of them if they're not helpful. So but yeah, so I think that that's really important, is to be open and honest and to destigmatize suicide, and that's something I'm really, really passionate about. So my idea for today was to just kind of talk to you all about some general COVID specific stats around suicide, and some good news, and also then to just kind of go through what we're doing at the state level and invite you in areas that you find most applicable to you to join us, because this is an everybody thing, all on deck. So through some of these grants and through some of our projects, there's going to be opportunities to become a trainer. There's going to be opportunity to host trainings, and all different sorts of things. So hopefully you'll feel called. And if I could give a little nod to our faith folks, you'll be called to speak up and ask me or email me and ways to get involved. So I also want to give a specific nod to folks not only that have lived experience of suicide, but those folks who use their experience of losing someone to suicide as a way of transforming that pain as meaning making. And there's lots of great loss support groups throughout our state. Larry McNabb is on here. He's someone who I know has done a lot of work. Holly's on here, I see her name, and she's worked with the AFSP, the American Foundation for Suicide Prevention, and you know, they do walks and they do all sorts of different things, and they're all still happening, even virtually. So I encourage folks to get involved. September is Suicide Prevention Month, so we're right on that. I've sent out some toolkits, and if you haven't gotten those, let me know. I can fill your social media full of you know, hashtags and campaigns. I think the AFSP's slogan or campaign for this year is keep going, hashtag keep going. And in COVID, times of COVID, that is really important advice, or just a tenet to just keep going. So if we don't have anything else, these earbuds are driving me nuts. I might just take them out. Can y'all still hear me okay?
Yep.
Oh, whew, that was distracting. I'm sorry. I'm with you now. All right. So some stats about where we're at in Kentucky and as it relates to suicide in the times of COVID. We are overall from March 1st to July 31st, we were overall down 19% as it compared to 2019. And so that's kind of maybe a notion that folks didn't expect, but they show, you know, history shows us that it's not actually during times of acute trauma like, you know, SARS or 9/11 or some a continent-wide trauma, that suicides happen typically 12 to 18 months. Suicides start to increase 12 to 18 months post that trauma. And so kind of to be aware that we're down now, but we're really working to create those safety nets for if and when we ever get out of COVID. And so hopefully that's soon. And so, yeah, so Lisa, the dates are March 1st to July 31st is our dates. So that is for our overall state data. I will say that, you know, we talked about target populations in that same time period. We've seen kind of an increased risk for suicides for males under 24 and under. That group is particularly being impacted during COVID, and actually for females over 65. We're seeing an increase in that demographic as well. Where we might be down across,
Beck,
yeah.
I'm so sorry. Can you repeat those stats one more time for us?
Yeah, so we are down 19% overall, but we have an increased risk for our males 24 and younger, and for our females over 65. And I can't write this down because it's not quite releasable yet. And so that's why I just have to tell you all. I know that the Kentucky Violent Death Reporting System, KVDRS, is one of our partners. They are working to create a COVID report that will be out very, very shortly. And that will have suicides, suicide attempts through the emergency department. It will hopefully also have EMS calls and National Suicide Prevention Lifeline calls. So it will entail all of those things.
Beck,
Yeah.
you said that the anticipated increase usually follows the crisis between 12 and 18 months. Did I get that right?
Yes. Yeah.
Okay.
it's if you follow individual traumas, it's kind of like that period where it's like post-traumatic symptoms start to happen. You have increased risk of, anxiety, depression. We've potentially all been white knuckling our mental health through COVID, and our reserves at that point start to get real low. So yes, so across the state, we're down, but there are two particular regions we're seeing an increase in. So our Four Rivers region, which is like Paducah, very far western Kentucky, they're seeing an increase of about 66% in their suicide. That's over, the 66% is over a 3-year average. So from 2019 to 2016, they've taken that 3-year average and compared it to 2022 or 2020, and they're seeing an increase of 66%. River Valley is lower from 2020 compared to 2019, but they're up, stats, man, data is hard. Numbers, right? So River Valley is down from the 3-year period before. So from 2016 to 2019, they're down, but 2019 to 2020, they're up. And so those are kind of some areas of hot spots, if you will, and those are actual suicides. And we're working together to get a map of EDs, suicide attempts through emergency departments and the such. So we'll send that out to folks as soon as we have that. So that, and I never ever like to talk about data. I think it's important to help us plan. But behind every stat is a person, is a family, is a community, is a school. And so I think it's good to help us plan. But I think we have to really, be aware of what's behind those numbers. And so,
Smith to the front office, please. Timmy Smith to the front office.
We just kind of keep that in mind. So that's the harder news. I mean, the good news is that we're down 90%. The even kind of better news for me is that our National Suicide Prevention Lifeline numbers are up 3%, which you're like, Beck, why is that like a good thing? And that means that people are reaching out for help. They're calling. So across the state, we're up 3% from when we started in January. From March 1st. And even we do that daily. We compare the call rate daily. And I will say that in July alone had a 17% increase into calls than July of 2019. So it tells me that if suicide and our National Suicide Prevention Lifeline increase, that's an effective intervention, and we need to really praise our folks for being there, answering the calls, and having someone to talk to at any time of the day. Always, that's confidential. It's toll free, no charge to folks, and somebody with a lot of training is answering that phone call. So. I do know that in Jefferson County, the National Suicide Prevention Lifeline has seen an increase in young Black males calling. And so that's really good news too. Potentially a demographic who hasn't taken part in therapy is reaching out. And I never like to have broad statements, but it is proving to be an effective intervention for folks in Jefferson County, particularly as racial unrest and the movement to honor Breonna Taylor's life is important. So there's that. But yes, Justa / Tara.
And yeah, I'm actually sitting in for her. So I had a little win at my church on Sunday. we got the first publication in our bulletin with the suicide prevention number and the veterans number and the website. So it is permanently placed in that. So that's something that has been a little, in talks for a little bit. And so I'm super excited, and my hope is to get it in as many churches in our community. So I just want to share that because that was awesome, because there was like 40 people at our church, and 40 people got to hold that number in their hand. And to me, that's a big win. So I just want to share that.
Yeah.
I knew you'd be excited about that.
Yeah, no, I love it. I love it. I love all the wins. And in work like this, you have to say out loud what the wins are. And getting a number in a church bulletin is huge. I led a QPR training last week for K-SPAN. And the following day, I got an email from a guy that was a participant that said, hey, I got to use my QPR training on a 12-year-old. And kind of gave me some more of the information, obviously keeping confidentiality, but, like how ironic that I just went through this training and then I had to use it and was able to successfully use it and get that young person to care. And so, yeah, wins like that are huge. And if you ever need me to help you celebrate a win, please feel free to share it, and I will do that. So that's kind of where we're at stats wise. If you're ever interested in your specific region or your county or your town, let me know and we can try to figure out some data for you. I try to always look on it, just not deaths, but attempts, and then also call centers for that county, or like National Suicide Prevention Lifeline calls to that county. So we can look at the whole picture of where we're doing, of what we're doing. So questions about any of that?
We have a question from Kathy Pronto. What do you use to identify increased risk for those male and female populations? I think she's talking about the what we know are the more at risk right now.
Yeah. So Kathy is actually my coworker, and she is the suicide prevention enhancement person, and so she works with all prevention centers. So if you're a regional prevention center staff, raise your hand. Lots of y'all on the call: Jamie, Mashana, Justa, I see you all, and they are they do a lot of great upstream prevention work, and so they work. I think 8 of the 14 regional prevention centers have suicide within their regional work plans. So as a target issue, and I'm probably butchering the words because I'm new to prevention, but it's on there. So Kathy's question was, where do we get that information? And one of the things that I saw was, when I first got into this job, one of the areas that I saw needed, kind of the most focus was our relationship with public health and the folks that held the data. So here we are as behavioral health folks, and here they are as public health folks, and they have all the actual data through vital statistics. And so one of the biggest wins that our department has had, I think this year, is that we meet now bi-weekly. Is that twice a month? Bi-monthly, sorry, that would be a lot of meetings. We meet bi-monthly with our partners at Public Health and KVDRS, Kentucky Violent Death Reporting, and KIPRIC, Kentucky Injury Prevention, I wrote it down, Research Center. So we work with them and we meet with them every 2 weeks and start to kind of look at what is the data showing us, where is the data, where are our hot spots, what can we use? And from that meeting, we then employ our regional prevention folks, our school folks, our clinician folks, to wrap around that region. So Kathy, that's a great question. So that information came from Kentucky Violent Death Reporting, and they were able to look at the deaths by suicide from March to July, and that's where they were able to pull that from. So
There's a question earlier in the chat from Bill McCann, who happens to be a board member of MHA Kentucky. So thanks, Bill. And Mary Malone, our board president, is also on the call. He said suicide is a serious problem, regardless of the numbers or stats, of course. He was wondering if you feel like the press has been accurate in their presentation of the numbers. Have they been downplayed, exaggerated? And how do we really think the pandemic has affected it? I think you sort of answered some of this, but if there's anything you wanted to add.
I think that safe messaging is always important when we're talking and reporting about suicide. The CDC came out a couple weeks ago that said the suicide kills more youth than COVID, which is a false equivalent, unfortunately, because youth haven't particularly been, the deaths of youth hasn't particularly been present in COVID. Not to say that that might not change, but I always kind of look behind those reports about what's the intent. And I think for me, the intent of that CDC report was to say, hey, this is something we need to be aware of and planning for. And they kind of just put it in ways that maybe grab our attention versus, like looking at the statewide specific data. So I think it's important that we're talking about it, that we're planning for it, that we're aware of it. But I worry about how it's represented, and that like it right now isn't mental wellness. I think is more needs to be more of the focus, and not just mental wellness like all of us, but like mental wellness within our occupations. Secondary traumatic stress is a real thing. And so those folks, that are answering that National Lifeline calls, the stories that they're hearing, the weight, the psychological despair and the weight of that story is on them and it affects them. And so mental wellness, I think, for our clinicians, because if we're the instruments of change, that's how sharp we have to be. And if we're not tending to, the instrument that we are, it's like plowing a field with a dull, with a dull instrument. And so I think that right now the emphasis for me should be on all of our wellness, and if we do that, and I think, we also have to be aware of, evictions and homelessness and, factors that really increase raise unemployment. So we've been working with the Lieutenant Governor's office to create kind of a training for them for their unemployment call center individuals. So people who have direct contact with folks who are having that financial stress and burden. We're working with them to make sure that they can identify warning signs, but more importantly, systematically know who to refer them to. Because I've found that if folks don't know the answer, a lot of folks could say, hey, are you thinking about suicide? But they're less likely if they don't know what to do if the answer is yes. And so my goal is to make sure, with partnerships with whoever, is that you have the confidence and the competence to ask the question, are you thinking about suicide? But, individually, I know what to do. And then also that the burden just isn't on me individually, but that we're putting those pathways to care in all of our systems. So our call centers, our unemployment offices. How many of you, by raise of hand on your reaction button, how many of you all in the jobs that you had to have CPR training? Right? Almost all of us. And if we're saying that mental wellness is the same as physical wellness, how many of you all as part of your job had to have QPR training? Yeah, so right, there's a difference. And so I think systematically and institutionally, we need to make sure that we are not just giving the lifeline number, which is important, but what do I do in the here and now if I have to ask somebody in my place of employment or in my church or in my sports league or whoever it is, and talk about increased risk. I'm really nervous about if we lose football season, the mental wellness of our football patrons is going to be kind of a scary thing to think about. So, so yeah, I hope that answers your questions about the media. And I think if we can focus on just our own mental health and that be the topic. But I do think that suicide needs to be talked about, especially if folks are experiencing risk. So it's kind of a fine line of when to talk about it and how to report it. And so, yeah, it's something that I'm still fine tuning within myself. Other questions?
Beck, it's Mashana. I love the fact that you gave the numbers. I was on something the other day that they said that the numbers, the percentage into the suicide hotline was like increased by like 600%. And for me, I was like, oh my gosh. But now that you're actually putting, when you've talked about like the state level, I'm wondering how much is that is true or what?
Yeah. So what I know to be true is that there's 2 separate call centers that SAMHSA funds. So the National Suicide Prevention Lifeline is one of them. It's the 1-800-273-TALK. And then there's now a disaster distress helpline. And they're sister agencies, but they're not the same number and they're not the same centers. And so the disaster distress calls have increased by over 300. I think I've heard upwards to 600%. But the National Suicide Prevention Lifeline numbers have stayed pretty static. And if anything, have just incrementally increased. And so that's the difference between the kind of the 2 numbers. So
Thank you for clarifying that.
That there is definitely that. So a little bit about what we're doing on a state level. I want to make sure that we get to our grants and our activities. So one of the things that I was handed right when I started this job was the National Suicide Prevention Lifeline Capacity Building Grant. And so when I started in September of last year, our answer rate was our in-state answer rate. So if somebody in Kentucky called the National Suicide Prevention Lifeline, our answer rate was 46%. So 46% of those callers were answered by a Kentucky-based crisis center. That means over 50% got sent to the backup call centers, which are not in Kentucky. They don't know anything about Kentucky. They have no resource list or any of those things. So whether those calls were always answered, but our preference is that they're answered regionally by folks who know our area, our resources, our all of that. So here is this lovely map, which we can send out to you. This is the Community Mental Health Centers map. And that's where, when you call that number, the 1-800 suicide prevention number, when you call that number, or if a person calls that number, they are routed to the regional prevention center or the regional CMHC that's closest to them area code wise. So when we started, 8 of those CMHC centers were NSPL, which is National Suicide Prevention Lifeline. 8 of the 14 were NSPL accredited, meaning that they could take those calls and they had the training and they had all of that. So we had 46% being answered. That's not great. And I can say through this grant and the efforts of this grant that we are now up to a 72% answer rate. So 72% of Kentuckians who call are routed to a Kentucky-based center. So somebody that knows Kentucky, that knows our regions, all of those kind of things. So we're really, really excited about that. I will also say that we got our 9th our NSPL accredited center, which is Pathways. So Pathways became our 9th center. New Vista is in the final stages to becoming our 10th accredited center. So those are big areas that we are working with. So I do like to just give a little nod out to them. And how many on here have heard of 988? Yeah, little show of hands. So 988 was just enacted by the FCC. There's legislation right now that they're trying to pass to get funding for it, but the FCC said that beginning in July 2022, the 988 number will replace the 1-800-273-TALK number. So the 988 will be essentially the 911 of mental health distress. So if you fall and you break a leg, you call 911. If you're in a mental health emergency, you're going to call 988. So that's really exciting news because it's less digits. It's easier to remember. And honestly, they're going to focus more holistically on mental health. And not necessarily just on suicide, suicide will be a big tenet to it, but they'll be able to kind of do that for all mental health emergencies. So if I have clinicians on here, that you can put that 988 on a safety plan, on any of those kind of things, and someone will be there to answer. It's none of the infrastructure changes. So the call centers that we talked about earlier will be the same exact call centers that will answer that 988 number. And I know that, so Teresa said when it will be enacted. Call centers have until July 2022 to become compliant. So if I've heard this statement 1,000 times, it's they're building the plane as they fly it. And so we're sending them good vibes. But yeah, so that is through SAMHSA funds, that is through FCC funds, and is a really exciting kind of thing. The worry and the emphasis on building the capacity or building the bandwidth of the call center is because that 988 number will increase capacity, it will increase use. And so we'll need more people answering the phones. And that's why we're really working on it right now.
Beck, I have a question. So, you said that it's, they have until the 2022. So is it already in working progress? No. So when will it begin? I'm sorry.
Great question. So right now, the only 988 number that is working is for, it's on Sorensen's, and it's for our deaf and hard of hearing Kentuckians. And it's a different kind of software. So 988 only works on their specific software. It is not nobody's using it right now. And we don't know exactly when the actual start date will be other than that July 2022. And so as you're planning, just keep that July 2022 number or date in your head, because I think that will be honestly the quickest that we can get the whole system kind of changed. So some systems need entire new like software and hardware and all of the technology to support that. So but it is very exciting. But yeah, so it's talking about what messaging, like here's 988, but don't call it yet, because you won't get it, nobody will answer the phone. So we're trying to advertise, but not too much. Well, let's say we're trying to celebrate, but not advertise, if that makes sense. Okay, so that's one of the big grants we're working on. Another one, which is really exciting. So another intervention is the crisis text line. So you all see 741-741 a lot. So it says text home or hello to 741-741. And this is where our younger people are using more. So this is the texting is definitely something our younger folks are using, which is good. So through KIPRIC, in a partnership and a grant through CDC, we are getting our own Kentucky crisis text line dashboard. Yeah, so I will have, Patty and I will have, Kathy, we will have access to topics that, because it's written, like text can be analyzed rather quickly. we'll have kind of darn near real-time topics or subject of texters, demographics of texters. So we'll have all of that information. Again, they're more readily able to kind of send out our helpful tribe to those places. Another cool thing with that is we get our own 3 Kentucky branded words. So we'll be able to have like our 3 words will focus on Kentucky youth, Kentucky farmers, and then we'll have a general Kentucky keyword. So it will say something like, you know, Kentucky youth, text Kentucky youth to 741-741, and then they'll be able to kind of have that then and there. And we'll be able to use that data on that as well. This year was the first year that legislation was passed that said that all student IDs in middle, high school, and post-secondary had to have the National Suicide Prevention Lifeline and the crisis text line on the back of that ID. And so that's really great to help our young people. And with that grant also, we have 50, just with that grant alone, we have 50 QPR train the trainer spots. So we'll be able to train 50 additional QPR trainers. And again, QPR is the CPR of suicide prevention. It's the, what can I do? How can I intervene right here and now until kind of more advanced or clinical care can happen. And so we'll have 50 additional trainers to be able to offer to the state just through that grant alone. So that's exciting. If you want to be a QPR trainer, holler at me. And QPR lasts about an hour and a half, and it is for anybody, I think they said like 10th grade and above. So like 16, 17 and above can partake in QPR. So yeah, thank you, Marcy. QPR stands for question, refer, and persuade. And it is what we call a gatekeeper training. So gatekeeper training is similar to that of CPR. It's where we have lots of people trained in something maybe kind of surface level or entry level, or a gate, if you will. I just lost my train of thought because my dog was being silly. That happens.
That's okay. QPR is a gatekeeper. You're trying to talk about how we are gatekeepers surface only.
So QPR trainers, I think every regional prevention center has at least 1 or 2 QPR trainers. They can be used with school staff, with faith-based, in workforces, in you know, your sewing club, your book club, anybody can partake in a QPR training, and that is really, really important. So keep that in mind if you're a non-clinical person, and if you want to be a part of our prevention efforts, that's an option. I'm trying to look at my time here. So that's kind of focused on our health department. So our local health departments, we'll use them as well as our prevention centers. So we also got, this is really exciting. We got Farm Bill money. So we got about $500,000 in Farm Bill money, really advocated for by Representative Brandon Reed and the Department of Ag's Farmer Stress and Suicide Group. So we are going to be creating an entire campaign around reducing rural farmer suicide. So we'll have a media campaign, we'll have social media, you know, we'll have the whole branded package. I want you to think Kentucky Proud. Everybody knows what that logo means. So we'll have something as marketable for rural suicide prevention or farmer suicide prevention kind of branded campaign, if you will. We're also creating a cultural appropriate training for farmers that we will use for primary care physicians, for you know, extension offices, for our crisis centers. So this will be developed by farmers for farmers, and really trying to target how to because they are by and large the largest demographics of folks in Kentucky that die by suicide is those white men, mostly rural white men, 30 and above, are the largest number of folks who die by suicide. Women, however, usually attempt more, but they do use less lethal means, meaning firearms. So males traditionally die by firearms, and yeah. So that's an important thing that we're working on. There'll be QPR trainers for that too. So if you're a rural Kentuckian and want to be a QPR trainer, and that you have access to all sorts of community resources in that rural area, USDA, extension offices, implement dealers. So if you sell John Deere and you want to do QPR training, holler at me. We'll get it worked out. If you work in a small college in rural Kentucky, just let me know, because we're really trying to create a large net for our rural folks. There also be an opportunity through 2 different grants. So our SOAR grant, which is our state opioid response grant, and this rural money to train clinicians. So if you're a clinician, give me your little ear for a second, because you can become an AMSR, which stands for Assessing and Managing Suicide Risk. It is the kind of way that we train clinicians to work with somebody who's having thoughts or behaviors of suicide. It's one of the ways. So we have an AMSR SUD new leader training coming up. So training would mean that you would train AMSR SUD. And AMSR SUD is about working with folks who have substance use disorder, who have been diagnosed with substance use disorder. And it really marries courtesy relapse or relapse prevention with suicide prevention and safety planning. So if you are a clinician and want to either receive AMSR training or become an AMSR trainer, let me know, because we have those also coming up. And hopefully I'll be sending out a link soon where you can kind of sign up for things as you want. You can always email me, but let me know. So AMSR SUD is a specialty of assessing and managing suicide risk that really addresses the correlation or the shared risk and protective factors of substance use disorder and suicide. So there is definitely, John Hopkins said that probably close to 1/3 of deaths that have been considered an overdose are actually probably a suicide. And so, that's a large number in Kentucky, especially, although our overdose rates are going down. So in most of the state, not all of the state. Thank you. Trying to think what else. Cool project that we're working on with Whitney Strong, Whitney Strong is a nonprofit that addresses gun safety. Whitney, if you all remember, a couple years ago, there was a shooting in the 5th Third in Cincinnati. And Whitney was a victim of that gun violence and was shot multiple times, survived, and kind of has made it her life's work to increasing firearm safety. And so we have partnered with Whitney Strong and bought 5,000 gun locks to be distributed to pediatricians, to be sent out with parents when kids are getting their immunizations or getting their well checks. So especially in the Louisville and Lexington areas, if you take your child to a pediatrician, let them know. And you could potentially have and it's a trigger lock. We'll also be talking Wednesday, we're hosting, or Whitney Strong is hosting another kind of talk like this with Senator Hornback and myself and Dr. Patty Clark, which is my boss. So we're going to be talking about suicides by firearm, and safe storage in that. In a state like Kentucky, talking about safe storage of firearms is fun and also has to be done. So it's important that we are talking about it. I think that's, oh, the biggest grant that we got is in Louisville, and we just got it about a month ago. And that is the SAMHSA COVID-19 Emergency Response Suicide Prevention Grant. And we are going to be working with lots of different Louisville partners. And we chose Louisville because they had the highest number of deaths from COVID. And also they have one of the highest rates of death of suicide. So that's why we specifically chose Jefferson County. But a passion of mine is that anytime someone comes into the emergency department or psychiatric hospital with suicide attempt, that I want them to be met with somebody who's had lived experience in the form of a peer support specialist. So our grant is going to cover the cost of 2 peer support specialists, so a billable role that have specific suicide lived experience. And so they'll meet them essentially and their families at the door when they come into the U of L hospital, and they'll walk with them along that path to hopeful recovery. And also they'll do warm handoffs from the hospital to the clinician in the communities. So there'll really be like a conduit to care, a bridge, however you want to say it. So that's the biggest part of that grant. We also are working with the Louisville Metro Health Department, Center for Health Equity, and T. Gonzalez, and we are helping fund a Jefferson County suicide prevention coordinator. So like my role, but specifically for Jefferson County. So that's really exciting. And there'll be lots of opportunities in Jefferson County to get CAMS training, AMSR training, QPR training, and potentially some of that will be to do the training for trainers too. So trying to think, Kathy, I'm missing something from that grant. Oh, Louisville Health Advisory Board, we're working with them. And then also a large chunk of that grant is going for the Center for Women and Families to help with victims of domestic violence and helping make sure that they have shelter and that they have been, you know, assessed and screened and treated for suicide, ideation, or behavior if need be. So that's a big part of that grant, which we're really excited. So we're working with our rural Kentuckians, we're working with our urban area of Louisville. So those are just some of the grant parts that we're doing. There are multiple coalitions, statewide coalitions that you can come up, be a part of. So that's how kind of Marcy and I have, you know, we've known each other for a bit, but that's kind of how we've really gotten to know each other through the Suicide Prevention Consortium of Kentucky. That's one group. And then there's another group, the Kentucky Suicide Prevention Group. And they both are statewide coalitions that are doing incredible work, as well as the American Foundation for Suicide, AFSP. So they are a state, we have a state chapter. Megan Cole, who's awesome, is the chair for that, or the executive director, I forget her title, but she is their coordinator. Holly, what's her role? She's gonna kick me for not knowing that, but so yeah, so lots of people doing lots of great things. I was actually really surprised when I got into this job about the work that is already being done. And so I feel like my role and the role of the department is to just connect the dots. Like, hey, Marcy, this is happening over here, or hey, you know, Lisa or Barbara, whoever, like, tell us what you want to do. I'm sure there's someone doing it across the state, and we want to be partners with you. Like I said, in all 120 counties, we have a regional prevention center that knows how to provide technical assistance and training, specifically as it relates to suicide. So let us know. We will be more than happy to figure out what the need is and to help you try to meet that need. So my goal is to keep expanding the net of safety. And once we have the net of safety up, then to start addressing some of the things that could be addressed as far as risk factors. So there was a study that said if you raise minimum wage by $1, you decrease suicides. And so if we can address systemically, financial concerns, racial disparities, and racism, the effect of racism, the effects of homophobia and transphobia, and all of the phobias that create such distress and psychological pain for folks, if we can start addressing those. The last 2 weeks, I trained over 200 CDWs, which is court designated workers, on suicide prevention within the LGBT youth community. And they were super receptive and really great, and hopefully can, they started asking the question about sexual orientation and gender identity in their interviews with their court involved youth. And so that's one of the biggest parts, is that we ask the questions, and that way we can have accurate data. So other questions? We have about 6 minutes, so I'll start. Yeah, I'll stop yakking, which those of you that know me is an effort.
Beck, we had a question earlier on the statistics about elderly. Do we have specific trends amongst our elderly other than the females over 65?
I don't have them right off the top of my head. My boss, Dr. Clark, she's like the data of data brains. And so we work really well together because they're kind of like Teflon in my brain, but she keeps them really well. And so, but if I can get you those specific data, if there's an area of the state that you want that data for, let me know. Also, you can all the time, individuals, agencies can all the time put a data request into the Kentucky Violent Death Reporting System. It's like kdvrs.org. We'll have to get you back, but
I'll find it, don't worry.
anybody can request data. And so Jacqueline Seals and Dr. Sabrina Brown, they can give you that data. I can give you the National Suicide Prevention. If you want to put us all on one, then we can get you the current data. So Ellen Walsh is our RPC director in Four Rivers, and she just asked, and we were able to give all of those numbers regionally for her. So if you are interested and want to know, let me know, and we'll get you hooked up to the right people.
I got that added in there. We had a question about media and its impact on suicide rates, whether there was a question of, things like 13 Reasons Why and such like that, how that impacts our suicide rates here in Kentucky.
Yeah. So studies have shown that that youth have heard the word and know the word suicide by the age of 8. And so I'm a huge advocate for any conversations that start to open up mental wellness conversations with people. So 13 Reasons Why, I have my own personal responses to it. I think movies, topics, any of those kind of things just done in isolation are not helpful for our youth. But when we can use those to start conversations and build the relationships, that's where I find that the real work is done, And so 13 Reasons Why, I think, had a discussion guide. So we don't recommend any kind of suicide prevention or awareness training with youth that doesn't come with either evidence-based or a curriculum, a discussion curriculum with it. So we have a good, better, best document. But in fact, right now, Kathy's her and I and Dr. Clark have been working nonstop for the last 2 weeks on getting our schools updated information, because we're moving, because of COVID-19 and the trauma that we're living in, like actual living in trauma right now. None of us are okay. Our bandwidths are all maxed out. So we've changed a little bit of our kind of warning signs, risk factors, traditional prevention, suicide prevention, to actually more safety planning. So if everybody doesn't have the My3 app downloaded and have 3 safety contacts in there, do it for all of us, because we're all at our ends, and our capacities are being kind of used rapidly during these times. So it's MY3. I'm going to type it in the chat. And it comes from, for you clinicians, it comes from the Brown and Stanley safety framework. And again, it's evidence-based, and it will have all of those in. Oh, sorry, I just chatted that to someone privately. Let me send it to someone, everybody.
Welcome to Zoom, right?
So it's an app. You can use it on Android or Apple devices, and it will help you kind of create your own safety plan, and you can use it for others. The last thing we want to do is everybody pull out your cell phones and make sure in your contacts that the Suicide Prevention Lifeline is in there. I'm going to send to Marcy, you might have our resource, like our PowerPoint of resources. Hey, Robbie. Oh, Rob, yeah. So the other thing that I forgot to mention, which applies to clinicians, is through the Kentucky Suicide Prevention Group, we now offer monthly clinical loss so if you're a clinician and have lost a client to suicide, we are offering an hour of a peer-led support group. And that happens on the first Mondays of every month, October 3rd, and I can get you that website and that registration. So if you're a clinician and you've lost a patient to suicide and are needing support, it's an entirely peer-led support, and it's just a place to kind of come confidentially talk about the effect that it's having on you, recognize that effect is probably not an individual experience, and to really kind of tap into collective wisdom and healing of that group. So that just started last month, and we're not doing one in September because it's right on Labor Day, but October 3rd will be the next hour-long clinical loss survivor group.
That's wonderful. Beck, thank you so much. I know that there were a few questions that we didn't get answered. Folks, I'll try to email everyone who registered for this event with links to all these references and resources, and I'll include your Suicide Prevention Week and Month information, Beck. I think we're done. Does everybody else have any major questions pressing?
No,
Yeah.
thank you both.
Yeah. Thanks all of us. So
Thank you all.
if you want to get involved, let us know, and we will find a way for you to be involved. If I know that most of you all already are, so thank you for that. And take care of yourself.
Exactly. Before stage 4, let's work on prevention.
Right. Yeah.
Thanks so much, Beck, for everything.
Yeah, I'll stay on for a bit if people want to stay on and have questions.
That's great.
Hey Beck, it's Lisa Johnson at Life Skills RPC. Where's the webinar for Wednesday going to be that you were talking about with Whitney Strong? Where can you get information about that?
Yeah, I can send it out, and I'll put it to, I can send it to Marcy, and also if you look up just Whitney Strong on Facebook, it's too. It's Zoom.
In the chat, actually, I found it and I put it in the chat. If you scroll up a little ways, I'll try to find it again and repost.
Okay, awesome. Thank you.
Lisa. And I got Sasha and Sheila added to the QPR list, so they should be
Awesome. Thank you. I appreciate that.
Anybody else? Questions?
Someone had asked if there were protective factors with COVID-19.
Yes. I think anything that decreases isolation is good. I personally do driveway donuts. So about once every other week or so, my best friend and I have donuts in the driveway. So any kind of social contact that you can have that's at a safe distance is good. So anything that can decrease that sense of isolation. I worry about, making sure that you are explicitly planning your own kind of you know, if I become not okay plan is helpful. And then asking clearly and directly those around you, like, are you okay? What do you need? How can I help you? I think the more that we can kind of lean into we're not all okay, that we can get that kind of mutual support from one another. And really just not faking it till you make it, but really kind of asking and stating what you need. I have regular check-ins with my people about their mental wellness. You know, are you okay? You know, where you at? What can we do? What do you need from me? And then I talk to them about mine too. And, you know, so I think that's helpful. I think anything that we can do to increase the lack of belonging or increase the sense of belonging, not lack of belonging, sense of belonging to things, you know, are important. There's, you know, one family had an entire series of Olympic events in their family, like not actually Olympic events, but they did like, you know, little fun games throughout the house, and they kept track. And, you know, I think finding a group of people to find joy anywhere you can is important. So.
Well, thanks so much, Beck. Thank you all for attending, and we're going to go ahead and wrap up.
All right, thank you.
Thank you so much, all.